think all of you know Dr. Chapa, Pediatric PI, and today he's going to talk to us about management of acute pancreatitis. Adrian?
All right. So it recently come to my attention that there's some variations in the way as physicians we manage patients with acute pancreatitis, not even in the pediatric population, but also in adults. And actually, a group from Cincinnati Children's actually did a simple questionnaire, 5 questions that they sent to faculty around Cincinnati area. And what they show is that everyone does whatever they think it's best for their patient, but it raised a big gap in a question that there's a gap in knowledge. And that triggered to kind of start building some guidelines about how should we address these patients, at least in the pediatric population. There you go. So I have absolutely no conflict of interest. So for today, we're going to talk briefly about the definition of pancreatitis and the clinical classification. We'll talk a little bit about the epidemiology and causes of pancreatitis in the pediatric population, a little bit of pathophysiology, but mostly we want to focus on the nutritional management and IV fluid management. And then we'll go through a glance of what the new guidelines from this year will suggest that we should do. So from a histologic perspective, or a pathologic perspective, pancreatitis is just a reversible inflammatory condition of the pancreas, parenchyma, as simple as that, okay? From the clinical perspective, the Atlanta classification back in 2012 did a criteria, which is a little bit simple, but they say you need at least 2 of these criteria to fit into acute pancreatitis. You need to have abdominal pain, which is compatible with pancreatic origin. And when we went to med school, we know it's typically the epigastric pain that radiates to the back and all that jazz, right? And plus, we need to have an amylase or lipase at least 3 times the upper limit of normal. And this is very important. Every lab has its own cutoff values, okay? So look at the cutoff value and make sure that value is at least 3 times the upper limit of normal. There's many other sources for amylase, okay, or even lipase. So unless it's more than 3 times, let's not call it pancreatitis. Or we need to have an image study that will raise concern for pancreatic inflammation. Okay? It has become a more common thing that we actually think in pediatrics. And there is this huge database called the Healthcare Cost Utilization Project that will look at the census of all the hospitals across across the country, especially looking at the discharge diagnosis. And what they did is they graphed 4 points in times from 2000 to 2009, and they noticed that there is a significant increase in discharge diagnosis of acute pancreatitis. Okay, and across from this time frame, there's at least 51% increase in the total cases in terms of incidence. Per 10,000 patients, it's almost a 60% increase in this 9-year period. And when we look at the different age brackets, yes, the kids, the toddler range is still pretty much unstable, but the rest are the ones that are showing this steep increase in incidence. When we look at the length of stay, it's pretty much unchanged, okay? In the acute pancreatitis, they all stay about a week. It's getting a little bit more expensive to treat these patients, but interestingly enough, look at this. The mortality is actually decreasing. And this might be because we're a little bit more aware about pancreatitis in kids, and we're trying to be more aggressive in the way we manage them. So that might account for this, okay? This other study from Cincinnati Children's, they used the same database, different points in time from 2006 to 2012. And interestingly enough, again, they saw this upward trend across the years. But look at this. The causes of acute pancreatitis secondary to the obesity, especially in the school age and teenage years, are actually on the rise. And in this table up here, you see that the gallstone, hyperlipidemia, triglyceridemia, and obesity-related things, which all are related to obesity for the most part, unless you have a messed up gene that makes you have hyperlipidemia or hypertriglyceridemia, they're all on the rise. So this goes along with our epidemic of obesity. which is really, really scary for us as pediatricians. And for our med peds, it's going to be the same thing. This is a world thing. India published their experiences, one single tertiary referral center, 320 patients, different time frames, and you can see it across all time frame. The overall incidence is increasing, and here they subdivided in acute pancreatitis, acute recurrent, and chronic pancreatitis. And of course, if we have more acute pancreatitis episodes, we're going to start seeing more chronic pancreatitis patients. So before it was thought that was just like an adult thing, it's not entirely true now. From Poland, for example, there's the same thing. I mean, it's just beating, I'm not trying to beat a dead horse here, but this is something that it's a phenomenon that we're seeing across the world, and we're going to be exposed more and more to manage patients with acute and chronic pancreatitis. So what causes pancreatitis in the pediatric population? Well, there's a lot of things, okay? And for your morning reports, here's how I like to divide it. My brain is divided in boxes, so I like to think in boxes, okay? So congenital anomalies, we're pediatricians, so we like to think about congenital things. So we have, of course, colorectal cysts, especially in the young kiddos, abdominal union of the pancreatic biliary junction, gallstones, infections of gallbladder, pancreatic division, tumors, more rare. Mostly this would be in adults, but if you have, I guess, a big Wilms tumor that's just too big and just compressing there, why not? Systemic disorders, okay? We don't see Reye syndrome anymore, I hope. Dr. Ulmer's area, so rheumatological diseases, sepsis, multi-organ failure due to sepsis, HUS, Hennes-Scholl-Purpur, IBD, CF. These are some of the systemic diseases that will also present with pancreatitis, especially in CF population. If they are the type of CF that they have some residual pancreatic function, those are the ones that are more likely to present with pancreatitis. Dr. Bucchini's area, so infections go, these are the most common viruses, but you can also have some parasites, some infections due to bacteria, especially gram-negative bacteria can also cause this. Okay, drugs, Dr. Giroudi area, L-asparagine. I mean, this is a #1 complication for this type of medication. It can cause a hemorrhagic pancreatitis, pretty devastating. Steroids, for our IBD patients, the medicines that we use for IBD, some seizure medications, some antibiotics. Alcohol, we're starting to see more and more in our teenage population. So don't think that because we are in peds, we should not ask about alcohol, especially in our teenage population. Metabolic, that's another thing. You have alpha-1 antitrypsin, diabetes, hypercalcemia, some lipid disorders. Malnutrition, high-calorie infusion if you overdo your TPN. Okay, of course, others, and genetics. And now we have more interest in the genetic profile of patients that have recurrent pancreatitis. And all these genes are involved in either activating the degradation of trypsin or deactivating once it's active. So these are like safety checks, if you may. Okay? And here it's a table where you have the percentage of all the type of causes of pancreatitis in several meta-analyses here in the US and outside. Of course, Japan will be the leading cause for anatomical problems, okay, like biliary and other things. And then, pretty much it's scattered all around, okay? But these are some of the things that we need to think when we're dealing with pancreatitis patients. When we talk about pancreatitis, we need to talk about a little bit of the physiology behind it, especially of our pancreatic enzymes. So we have trypsinogen, which is the inactive form of trypsin. It's inside your pancreatic acids, inside what we call chymogen, which is protected there from stuff that should not be acting upon, okay? And we have some things that I put in a green box that will activate the trypsinogen to make it trypsin, right? And we have enterokinase in your small bowel. There is an enterokinase deficiency, by the way, it might come in your boards. We have cathepsin B. Of course, trypsin itself, it's a stimulator of trypsinogen, and of course, some neutrophil enzymes. All these things will activate trypsinogen, and when it activates it, it converts it to trypsin inside the pancreas. So you need to have some sort of check. to say, like, okay, this is bad, so let's try to prevent further damage. So we do have that. And here we have alpha-2 microglobulin, alpha-1 trypsin, and this is the pancreatic secretory protein that it's supposed to bind. All of this bind to the trypsin to kind of prevent doing stupid things in their pancreas, right? And of course, trypsin will also activate the other pancreatic enzymes, which will be your chymotrypsin, elastase, and all that kind of things, okay? Now here's where your genes come into play. So we have our trypsinogen here inside our zymogen, all happy, just sleeping, okay? And we know that calcium will activate trypsinogen and will convert it to trypsin. So hypercalcemia, that's why we kind of look for that, okay? Once it's active, trypsin itself will further put more gas in the fire and will activate more trypsinogen, okay? Hypocalcemia tend to inhibit the degradation of trypsin, but trypsin itself kind of also push trypsin to be degraded. Okay, here we have some genes that are when they're present, they're supposed to enhance degradation of trypsin, and of course, when we have a mutation, we don't have this gene. Therefore, we are just putting more fuel to the fire, but we don't have water to extinguish it, right? Here we have our CFTR gene. Of course, that will also come into play. SPINK1, this is another gene that's supposed to inhibit trypsin activation of trypsinogen. Okay, so we have this is how the genes that I mentioned before come into play in terms of trying to prevent this thing going out of whack and just misbehaving, okay? So in an oversimplified way of how things get messed up in our pancreas, we have a blockage or damage from either a drug, a trauma, whatnot, infection, a damage in our collecting ducts or an us in our cells. And this will lead to activation and release of our digestive enzymes outside of our gut. And then this leads to autodigestion of the pancreas parenchyma that leads to inflammation, production of inflammatory cytokines, and these will lead to pancreatic necrosis and blood vessel occlusion, okay, or disruption, SIRS, sepsis, and death if we don't do anything about it. This is a very oversimplified thing, okay? Because we have students, I put a couple of slides for students, but you know, history is very, very important. In anything in medicine, H&Ps should be the first thing before you toss someone into the CT scan machine. History, symptoms are very, very important. And I put back the first slide here. Remember our criteria to diagnose pancreatitis. But always you need to ask about what medicines, what crap from the healthcare store they're getting, herbs, supplements, all that type of stuff we need to ask, okay? And so oftentimes I always ask them, well, even if you don't think it's pertinent from my standpoint as a GI, I still need to know what stuff you're taking. And say, oh, well, yeah, you know, I'm giving St. Worth, John, Root, whatever for menstrual period, but you're a GI, you don't care about menstrual periods. Like, yeah, but your liver, you have liver. So yeah, so always ask about this type of stuff, right? Family history is also an important part, okay? And of course, physical exam, you know, you have this tenderness. If you have jaundice, you think more of a biliary type of pancreatitis. And for the students, you have these pictures. So what's this? The colon sign or Gray Turner? Student? Yeah, exactly, colon. And this would be your Turner syndrome. So if this is your ribs, and this is the flank, so that makes a T, so that will be an easy way for you to remember. This is a Turner sign, and this you're just imagining a C around your belly button, the colon. There you go. You will not miss it for your step 1, 2, 3, and for your in-training exams, and hopefully for your board. So I'm not accountable for not putting that in the slide. Labs. So in PEDS we pamper you guys, but medicine and especially surgery are very picky about tiny insignificant facts. So here are they. Amylase, they tend to peak in 48 hours and tend to remain elevated for about 4 days, okay? It can be falsely elevated, okay, in small bowel obstruction, mesenteric ischemia, tubal ovarian disease, ruptured, twisted ovaries, ruptured ovarian cyst, you know, renal disease. So as you can see, it's not very specific for pancreas, and many other things should can also increase this, rarely above 3 times the upper limit of normal. Okay, lipase is more specific for pancreas and tend to remain elevated for a little bit longer time, 8 to 14 days, okay? Longer than amylase, okay? We normally ask for bilirubins and liver biochemistry, but again, there is some component of biliary disease that triggers pancreatitis, so we need to know. Okay, triglycerides and calcium is super, super important. And of course, if this is the second or the third, please consider doing gene tests for this type of patients, okay? And here it is. So these are 3 of the most common mutations, okay? And they're present about a third of the patients that present with acute recurrent pancreatitis or with chronic pancreatitis. So a third patient, it's not a negligible percentage, right? And if this other study, what they did is they look exactly about the frequency of each of these mutations in patients that presents. And of course, CFTR gene is one of the most common, followed by SPINK and PRSS1, okay? Ultrasound, it's a good starting point, no radiation. We should have, every place should have one. And what do we look for? Well, alter in the echogenicity, inflammation will give you that, but you're looking for dilated pancreatic bile ducts, stones, sludge, signs of obstruction, signs that you need to have an ERCP done to fix the problem, okay? You can have also calcifications in the pancreas, but also you're looking, remember we talked about anatomical problems like colodocal cysts and things like that, so this is a good way to do. If you want to have more ductal malformations, you have MRCP. It will give you, without radiation, a very good description about all the biliary tree and the pancreatic structures. And of course, ERCP, it's an invasive procedure, but also will give you information plus the benefit of some therapeutic intervention. Okay, so how do we classify this? So after that survey that I mentioned, there's the creation of the INSPIRE criteria, the INSPIRE group, which is a national, international group of wise guys that, they happen to be junkies for pancreas, and they decide to get together and kind of make an adaptation of what adult literature into peds. So first 3 questions you need to ask. Okay, is there any organ dysfunction? So we already made the 3 criteria of pancreatitis, so fine. Next question, do we have organ dysfunction? And we'll get there to that definition. So if the answer is no, okay, then the second question, are there any local complications from the pancreatitis or an exacerbation of underlying condition? If the answer is no, you're dealing with a mild pancreatitis. If the answer is yes, there's some local complications on image studies, or we messed up something that was not supposed to be messed up, then you are in a moderately severe pancreatitis. On the other side, if you think that there is organ dysfunction, then you go, is it lasting less than 2 days or more than 2 days? Less than 2 days, then you're dealing with moderately severe pancreatitis. And if it's a persistent thing, you should be talking with Dr. Scott, Dr. Green, things like that, because those kids are really sick or can get really, really sick really fast. This is a backstabbing son of a gun disease. So you turn your back on it, and it will backstab you. And anyone who actually has dealt with this, I see Dr. Scott back there, he'll say like, yes, it will backstab you if you don't treat it with respect. So this is the criteria from the International Pediatric Sepsis Society. We steal it from them. But pretty much it defines what are the criteria for cardiovascular dysfunction, respiratory dysfunction, and renal dysfunction. So that is published, and when you go through your ICU rotation, you'll get all these things, and you need to have them on your tiptoes. So when we look at the time frame, why do we care about how we classify this? It's very simple, because you have your pancreatitis. Most of them will have interstitial or just edematous pancreas. They'll have a transient organ failure, and look at this. Mortality is not that bad. Okay, some of them will have pseudocysts, some of them will resolve without doing intervention. That's okay. The problem is these fellows, the ones that develop more severe pancreatitis, necrosis of your pancreas. Okay, these are the ones that will have a persistent organ failure. Okay, these are the ones that will become infected, and once you become infected, well, your mortality raises to 10 or 30%. So again, these are the ones that you really need to be more aware of them. Okay, so trying to predict who is going to get in trouble, Well, adults back in the 1974 created ransom criteria. And we still, I don't know if we still use them right now anymore. I think they're good, but we have all the scores. And they use several clinical and paraclinical criteria at admission and at 48 hours. Okay, and predicted severe progression to severe pancreatitis fairly well. Later in 1985, Balthasar Ransom got together, a couple of beers, and then they created this CT scan scoring system when they graded based on the abnormalities of the pancreas, not considering necrosis. Necrosis came back all the way to the 1990s, and they just did, okay, let's do the modified CT severity score, which incorporated just necrosis here. And of course, the more messed up you are, the more necrosis you are, the sicker you are. Very simple and straightforward, right? And then in 2005, they created the Apache 2 score, right? It's a very simple score. Everyone should have it on top of your mind, okay? It's very simple, see? No, I'm just kidding. You just have a calculator in your phone and you create it, right? You can have your, but this is more for adult ICU setting, okay? So what do we have in peds? Well, it was not until 2002 that a pediatric Midwest Pediatric Society for whatever, they created a similar thing of ransom criteria. On admission, they have some clinical and paraclinical information, and again at 48 hours. And then if you have all these things, then you have your score system, and of course, the higher the score, the greater the chance of progressing to severe pancreatitis, or your mortality also increases, right? Then later on, we try to simplify things because who is going to have all this on their minds, right? So in 2003, we said, okay, let's make this more simple. 24 hours, lipase level. More than 7 times the upper limit of normal, you have 80% chance to progressing for severe pancreatitis. Simple. 7, okay. So then in 2013, some other people say, okay, well, if those patients, those that are also malnourished, will tend to have a prolonged length of stay. And interestingly enough, African-American population tend to have more ICU admissions than the other patients. And then in 2016, from Cincinnati, in collaboration with, I think, Columbus or something like that, they tried to simplify it more, and they say, okay, you've had high lipase, low albumin, high white count at 24 hours admission. The chances of progressing to severe pancreatitis is about 76%. So everyone is trying to predict on our first encounter, how is that patient going to behave? And because of the chance of things getting really out of control. Other people say like, no, let's do this, CRP. Let's look at CRP. So CRP with a cutoff of 50 milligram per deciliter at the second day of admission has an odds ratio of 10. Oh, not that bad, right? And a good sensitivity and a negative predictive value. Procalcitonin came later on, and everyone got warm and fuzzy about feelings about this. And with a cutoff of more than 0.5, an odds ratio of 4 to predict who will become or who will progress to severe pancreatitis. And then other people use the same 7, more than 7 for lipase, plus a calcium trough of less than 8. This is our value for America. This is for Europe. We'll have a sensitivity almost of 90% to predict. Okay, so there's a lot of people actually very interested in knowing who will get messed up during that admission. Who should I be more afraid of, right? So this is a meta-analysis, a table from a meta-analysis that they look at all the adult criteria, all the scoring systems that used for pancreatitis. Here's your ransom criteria, 94% for chances to predicting severity. Of course, it's not very good for pancreas necrosis. And you look at the CT scores, of course, it's awesome for the pancreas. But anyways, all do fairly well in predicting who will get really messed up, really sick, and who might even die. So that's why we do labs. We constantly reassess patients to try to see how are they going to behave. Going more into fluid therapy. So intravenous fluid resuscitation is the cornerstone of management of pancreatitis, okay? There's more questions than answers, okay? Whoever has the answer, I think they're lying. No, I'm just kidding. So the first question is, what type of IV fluid should we use, okay? How aggressive should I use? And those who are in med-peds might have already encountered some discrepancies among your attendings with these questions. And then, how long do we need to keep the IV fluids on? And if we steal this goal-directed therapy that people in the ICU use for sepsis and codes and things, would that help us with the management of pancreatitis? I mean, those are kind of pertinent questions that come, at least when I round. Okay, spoiler alert, no one knows. But anyways, I'll put a couple of papers here. So this paper was, I think, a hallmark paper, was published in 2011. They used lactate ringer, and they say that it actually reduced systemic inflammation compared to normal saline. So what they did in this study was interesting. It's a randomized controlled trial. They used goal-directed fluid therapy versus standard fluid therapy. So meaning, I will give enough therapy to keep your systolic pressure above X point, your MAP above X point, your peripheral perfusion above X point. Or I'll just go nuts and open that drip and have an intern squeeze that back and just rush. And then the other thing that they look for is lactate ringer versus saline, and in patients with acute pancreatitis. Interestingly enough, they found no difference in the amount of fluid given with which way you went, either more restrictive or more liberal. They all got the same plus minus 500 ml, so it's not a biggie. Goal-directed therapy did not improve SIRS or CRP, but what they did found was that SIRS at 24 hours was significantly reduced in patients who got lactate ringer by 84%, okay? And also there was a CRP reduction by 51% of 51 versus 104. So their conclusion is, lactate ringer seems to be kind of the new thing, and it helps us. So then the next question is how? How on earth this would help? So these other people, they did, this is from Europe, they used lactate ringer, they used normal saline in pancreatitis, and they found similar things. So the CRP tend to be lower in the 3 points in time they observed this in the patients that received lactate ringer. Okay? If you're really picky, you're going to tell me, but look, Dr. Chapa, it's super, super long, the distribution. Yeah, but okay, it was significant. Let's go with it. And then what they did is they used a cell culture, okay? And they used human monocyte cells. And then they stimulated with LPS, which is a byproduct of gram-negative bugs, and make them all start producing stuff. And then they expose them to normal saline, lactate ringer, or just lactate without ringer, right? And they noticed that there was a decreased expression of interleukin-1B and tumor necrosis factor alpha in those cells that were stimulated but exposed to lactate ringer. Therefore, that's how they assume this is working, by decreasing the production of inflammatory cytokines. Okay? So have this been tried in pediatrics? Well, yes, this is hot off the press in pediatrics. And this was actually, it's more of an abstract of one of the meetings. And what they did is, again, they used lactate ringers versus normal saline in peds acute pancreatitis. And what they noticed is that after 24 hours, their mean CRP came significantly lower, okay, versus those that were on lactate ringers. Some people say, well, these people were sicker than this one, but yeah, okay, fine. But at least you start thinking of it, and you start making people that have bigger centers to look more into this type of things in pediatrics, right? So lactate ringer seems to be the choice. If you go to talk to any adult GI, they'll say like, do lactate ringer, don't do anything else. Simple as that. How much? 2 times maintenance. Now, some people will say, do it for at least 24, 48 hours and then go back. Some people say, like, oh, well, hold on. I mean, if you're getting already complications, you need to back off. Well, it all depends on your on the clinical situation. You can always direct the patient if you're overloading them, but you can fix if they're dead, right? So, nutrition. So, should we keep patients MPO? When should we start feeding? And when I went to med school, long time ago, oh my God, the rationale was like, you keep patients MPO until they have no pain. And if they have a little pain, don't feed. If their lipase is high, don't feed. So it was a very different era, okay? how do we start PO and G and D and J? How do we, and what do we feed the patient? So, and should we stop the nutrition if the enzymes go up? These are all questions that typically I get asked. So let's talk about what's the mechanism for disruption of the gut barrier in patients with severe acute pancreatitis? Well, to start with, there's enteral nutrition depletion, right? And there is a problem with the intestinal microcirculation, okay, that leads to ischemia and reperfusion injury. And this, of course, leads to release of inflammatory cytokines and mediators. There will be apoptosis of the intestinal mucosal cells. And then this all lead to bacterial overgrowth, an increase of virulence, commensal microbiota. Okay? So what are the harmful consequences of just giving TPN and nothing and through the gut? Well, again, you have enteral deprivation, you have atrophy of your mucosa, especially of your lymphoid tissue associated in your GI tract. You have gut inflammatory proteins that start to be produced, tumor necrosis factor alpha, you have interleukin-1, toll-like receptor 4, and then you start losing your barrier function, so your tight junction proteins and your cannot pronounce that word, that protein, they all start not working. So then you have a leaky gut, okay? And of course, there will be change in your microbiota more towards a more pro-inflammatory. All these things will lead to bacterial translocation and endotoxin translocation, mostly your LPS from your gram-negatives. You have also pancreatic enzyme translocation, and you have a lot of cytotoxic and inflammatory mediators that also translocate. All of this leads to sepsis and organ failure, and if you don't correct this, you die, right? So what are the benefits of using some food through the gut? Well, very simple. We have some big models that have demonstrated that early enteral nutrition actually is associated with better intestinal function, okay? And therefore less bacterial translocation. And when they measure plasma levels of all this and the toxins and all that, they tend to have a lesser level than patients that, or pigs that were on parenteral nutrition. So, and then they try to replicate this on rats, and they say, okay, early enteral nutrition in little rats that have severe pancreatitis are associated with, again, better intestinal immune function and better intestinal integrity and less bacterial translocation. So this is an animal model. And there are many, many other studies that shows that, you know, if you feed the gut, your outcomes will be a little bit on the better side, okay? So how does all come into play? Well, you have some issues, some substances, bile acid, alcohol, fatty acids, or there are fatty acid derivatives, especially in your hyperlipidemia, hypertriglyceridemia, pancreatitis. All these things will stimulate calcium overload, which will cause some mitochondrial injury and depletion of your phosphate and your ATP. You don't have ATP, you don't have gas. Your car won't run, okay? And this lack of ATP will also lead to some ductal cell damage, and especially your CFTR channel will start having dysfunction, so you won't have good exchange of chloride in the water, okay? So these are some events that occur in pancreatitis. So if you are still not on top of nutrition, then how are we going to start putting back some of these things into the patient's body? There's a lot of studies, and I summarize them here. This is a really busy table, but the take-home message is that this is nothing new. This has been studied back from 2004 and all the way here. And many of these randomized controlled trials, you see all these patients' numbers, they'll show that early enteral nutrition is associated with less infections, less hospital stay, less mortality, less ICU admissions, less pancreatic complications, less line infections. So all of this thing, I think it's a quite robust evidence that suggests that using the gut is the way to go, okay? So in peds, so early, then we look at similar things. And this paper was, I think, a hallmark paper for pediatrics. That's why it was published in a very, very good art and very, very good journal. What they did is they look at patients with acute severe pancreatitis. And this is from Cincinnati. And they said, let's just be very aggressive with the fluid. I don't care which. Just be aggressive with the fluid that you're going to give. Okay? Plus, let's feed them. And how they define early versus not early is 24 hours. Are you feeding them within the first day or so or not? And what they notice is that, here you go, patients that were fed, okay, had better outcomes than patients that were not fed. Of course, here is also if you have IV fluids, low IV fluids or high IV fluids or whatnot, right? So, but overall, feeding actually decreased lengths of stay. And when you look at progression of severity of the pancreatitis, patients that were fed plus had under the aggressive fluid resuscitation arm, they tend to have less progression for severe pancreatitis and complications. But overall, if you look, just feeding itself prevents progression of pancreatitis. And this is from a pediatric cohort in Cincinnati, really good data. So here you go. You have, these are your 4 arms, and you see here, readmission rate tend to be lower in the patients that had high or a more aggressive fluid resuscitation, defined at least as a 1.5 maintenance to 2, okay, plus enteral feeding, so they have less readmissions, less admissions to the ICU. I mean, look, MPO and maintenance IV fluids or less than maintenance, 20% of admission to the ICU. I mean, that's pretty good, pretty big. 35 progressed to severe pancreatitis versus only 4%. So it helps to feed the patients, especially pediatric patients, okay? This other paper, same guys, just publishing different stuff. They noticed that the lipase level had a negative correlation with the fat intake. So the greater the fat intake you're going to get, the lesser the lipase you're going to get, okay? And then the pain rate tended to be better for those that actually were being fed. Okay, so there is some benefit in all this. So should we just start freaking out? Here's where the art of medicine comes into play. And you guys have heard me saying this many, many times. All of this is science, and it's awesome that you guys read, but the most important thing is that you learn how to apply this thing to your specific patient. And you need to constantly be reassessing your patient, okay? It's not this, I'm not just going to feed someone that I think is going to shock. Okay, and that Dr. Scott might need to intubate the patient. I mean, see my point? No, you need to see the whole picture. Okay. So, what are the benefits of early enteral nutrition in mild pancreatitis, at least in pediatrics? Well, this group they had more than 100 patients. They had, what they did is pediatric-driven nutrition versus treatment therapy directed nutrition, meaning let them eat whatever the hell they want, when they want, versus let's have some white coat doctor tell them what to eat, when to eat, and all of that. Simple as that, okay? And what they notice is that if you let the patients eat whenever they feel that they are ready to, okay, they had a length of stay shorter than those that were told what to do, okay? It sounds almost like teenagers, okay? Of course, they had shorter MPO status, about 20 hours less. Okay, and there's no report. The most important thing, there is no reported complications from letting the patients eat when they think they're ready. Okay, so in Mexico we have a fault saying that says, "Enfermo que come, caga y mea, que el diablo se lo crea." In English you cannot translate, but in essence is whoever is sick that is eating, pooping, and peeing, not even the devil will believe they're sick. Okay, sounds better in Spanish. It's more catchy. So listen to your patients. Listen to your patients, okay? This meta-analysis is a meta-analysis of early enteral nutrition within the first, specifically looking at the first 24 hours, okay, of admission in, and they look at clinical outcomes for acute pancreatitis. And this showed that early enteral nutrition reduces actually multi-organ failure in the context of acute pancreatitis. And, here are your odd ratios of 0.3. I mean, it's pretty good. And there is a decrease then in mortality, infections, and adverse events. And then they go ahead and they put this fancy table saying, well, early enteral nutrition and mortality, how does it go? Well, specifically for pancreatitis and mortality? Well, it decreases mortality, multi-organ failure, and rate of infections. So lastly, going for our NASPGHAN guidelines, which were just published, they say, well, let's do this. Let's start stating out what we do know. We know that we don't know anything, okay? Let's start with that. And let's assume also that all the evidence that is there is not the greatest. So part of this comes from what we actually have available, plus some expert opinion, which is a valuable thing, okay? So in terms of fluid, they say, use crystalloids, okay? I don't care which one you choose, lactate ringer, normal saline. They do make a comment. You know, based on the adult literature, there might be a role in using lactate ringers. There are some PEDS trials that have shown similar effect, but there's still not robust evidence to make a 1A recommendation for this, okay? So take it as it is, okay? If you ask me what fluid I use, lactate ringers, okay? You do a bolus, of course, 10 to 20 ml per kilo. But here's the thing. ER loves to give boluses. You walk there, you get CT scan and fluid bolus, right? But hold on, I just talked to you guys. Look at the patient, do a physical exam. Are they hemodynamically compromised? Yes or no? If they're no, then why are you just overloading the patient? So if they're hemodynamically compromised, yeah, sure. Adults tend to get about 3 to 4 liters within the first 24 hours, okay? The rate normally should be more than 1.5 to 2 maintenance IV fluids. And while you're doing this, you need to monitor urine output in those first 24 to 48 hours. So you need to be on top of nursing staff. Please don't say 1P. Tell me exactly how much it's going in and how much is coming out. It's very, very important, okay? We need to monitor these patients. We need to monitor the heart, the respiratory rate, of course, the renal status. We normally focus at the urine output, okay? And we want to keep this urine output above 0.5 to 1 ml per kilo per hour, okay? There is a role of looking at BUN and creatinine, and of course, urine output in the first 48 hours of admissions, okay? Because it would be a good surrogate for acute kidney injury that can present in patients with acute pancreatitis. Pain management. I get this question very often. Dr. Chapa, why are you giving opioids? Step 1 told me that sphincter OD will choke and he'll get worse. Nah, there's not enough evidence to do that. So they say, use acetaminophen or NSAIDs for pain. Like, seriously, dude? I mean, whoever have rotated with me know that I have only 3 rules for using opioids. Number 1, you have acute severe pancreatitis, you burn 95% or more of your body, or you're dying and it's for compassionate use. I do not use opioids for anything than that. So, yes, you can do it. It's a really bad pain. So, be proactive about pain, okay? It's not okay. You don't get extra points for being super tough and withstanding bad pain, okay? There's nothing wrong with feeling good. Don't overdo it, by the way. We want them breathing. Nutrition, it's an important thing. They acknowledge that. They say, well, early enteral nutrition will decrease length of stay and complications. So, very simple for you. If the gut works, use it. And this will apply for almost anything you could possibly think, okay? If the gut works, use it. If the gut does not work and you anticipate that for more than 5 days you are not going to use that gut, okay, starvation and death versus TPN. Please give TPN. I mean, but again, don't wait until day 6 to start the TPN. If you anticipate that for whatever reason you are not going to use that gut for more than 5 days, why you wait until day 6 to start TPN? You start from the beginning. This is a really, really sick patient. Likely he's in the ICU. Yeah, why not? Antibiotics only, and only if you have a documented infection. And Dr. Buchini says, thank you very much for that. Yes, there is no role of prophylactic antibiotic use in pancreatitis, just in case, just a touch, just a tad, just for this. No. If you don't have an infection, you do not use. And they can get fever. And they get fever because I already told you they have interleukin-1, and that causes fever. So not all fevers are Dr. Buchini's problem, okay? They can have fever because they have a massive release of inflammatory mediators. So if you have documented infection, yes, go ahead and give antibiotics. If not, Dr. Bucchini, Bancheri, and me will go, don't do, bad doctor. Okay? I woke up a couple of you guys, okay? In summary, acute pancreatitis is on the rise, okay? Punch hard, punch first, and maybe you don't have to punch a second time. That's Bruce Lee, by the way, okay? And early enteral nutrition does improve outcomes and reduces complications, and early aggressive fluid resuscitation also will improve by decreasing systemic inflammatory response, decreasing inflammation, and improve outcomes, okay? Questions? I like Bruce Lee, by the way. I thought there's no one else that, since that him, that it matches to him. Anyways, questions? No?
All right. Here,
Shoot.
I
I shouldn't say that in a Republican state, right? They might have guns.
You're safe saying it.
Okay. Oh no, you're California girl. You're fine. Okay.
In the severity algorithm, one of the questions was local pancreatic complications. I was just wondering what the local pancreatic complications are.
You have fluids. You have fluid. You have necrosis. Well, necrosis you'll be more severe, but yeah, meaning you did a CT scan and it's something else that just a little bit of edematous. You're having fluid collection around it, or you're having that. Sometimes you can also have some thrombosis of some vessels around it. So you have a complication related to pancreas.
Okay.
is there a need for timing for the ultrasound or the CT scan?
Yes. So that is another biggie question.
Repeat the question. I didn't hear it.
The question is, what's the optimal timing to do image studies? And that's a matter of debate. Some people would say that it's okay to do an ultrasound on admission, especially because you're looking for the biliary pancreatitis, things that you can fix right now, and I think that is coming mostly from adult literature. But in terms of CT scan, I don't think they do it during the first 24 hours because some of the changes you will not see them initially, so you wait a little longer for that. And again, I will not scan a patient unless they're getting worse. So if they got better and then they got worse, then okay, go and look for problems. Or if they never got better, you're doing all the right things and they're just not getting better. So okay, fine, let's go ahead and do.
All right. Other questions, comments? If not, thank you very much. Great.